Symptoms and signs. A few symptoms and signs are described in this chapter which I feel deserve special mention and are not thoroughly dealt with elsewhere. Pain. This is a very common symptom and all of us must have experienced pain sometime or the other. The word pain is derived from Latin word pona, which means penalty or punishment. Pain should not be confused with tenderness. The patient feels pain, while the doctor elicits tenderness. Tenderness means pain which occurs in response to a stimulus given by somebody, usually from the doctor. So pain is a symptom and tenderness is a sign. Basically 4 types of pain are noticed: 1. Superficial, 2. Segmental, 3. Deep or visceral, and 4. Psychogenic or central. 1. Superficial pain. This occurs due to direct irritation of the peripheral nerve endings in the superficial tissue. Such irritation may be by chemical or mechanical or thermal or electric edge. The superficial pain is sharp and can be pointed with a fingertip. 2. Segmental pain. This occurs due to irritation of a sensory nerve trunk or root. This is located in a particular dermatome of the body supplied by the affected sensory nerve trunk or root. 3. Deep pain. This pain occurs due to irritation of deep structures of the body, for example the deep fascia, the muscles, the tendons, the bones, the joints and the viscera. The pain sensation from the affected structure is conveyed to the brain either by somatic nerve or by the autonomic nervous system. The deep pain is vague compared to the superficial pain and may be one of the various types which are described below. The deep pain is vaguely localized in comparison to the superficial pain. The deep pain may be referred to some other area of the body due to common area of representation in the spinal cord, supplied by the same segment. The deep pain may cause involuntary spasm of the skeletal muscles supplied by the same spinal cord segment. 4. Psychogenic pain. In this condition pain arises from the brain, which may be a functional pain, either emotional or hysterical, or due to lesions in the thalamus or spinothalamic tract, or due to causalgia. Majority of the surgical patients come to the surgeon with the complaint of pain. A careful HI story must be taken about pain so that it may help to reach the diagnosis. Followings are the various original site of pain. The patient should be asked to locate the site of pain with his fingertip. FT must be remembered that when the patient comes to the surgeon the site of pain. 12A Manual on clinical surgery may have changed, but it is highly important to know the original site of pain. Where did the pain start? In many cases, particularly in abdominal pain, the patient may not be able to point with a fingertip, instead he uses his whole hand. So exact localization may not be possible, particularly in case of deep pain originating in thoracic or abdominal viscus. A patient with acute appendicitis when brought to the surgeon may locate pain at the right iliac fossa, but when he is asked where did the pain start, his answer is often in the umbilical region, and now it is in the right iliac fossa. This simple history is highly important to come to the diagnosis of acute appendicitis, and this history only differentiates this condition from many others. Origin and mode of onset. ALT may be possible to know from the patient the time of onset of pain and mode of onset. A long continued pain with insidious onset indicates chronic nature of the disease, for example chronic pancreatitis, chronic peptic ulcer, subacute appendicitis, etc. Whereas recent onset of pain with sudden arrival indicates acute nature of the disease, for example acute pancreatitis, acute appendicitis, rupture of aneurysm, etc. Inquire into how did the pain start. When the pain starts after a trauma, the cause of the pain must be traumatic, for example a sprain, or a fracture or dislocation or rupture of kidney or rupture of liver, etc. Severity. This of course is not so important to come to a diagnosis. Individuals often react differently to pain. A severe pain to one person may be simple dull ache to another. However, a few diseases are known to produce severe pain, for example acute pancreatitis, biliary colic, perforated peptic ulcer, dissecting aneurysm of aorta, etc. Nature of the pain. It is of great importance to know the character or nature of the pain. It often helps to come to a diagnosis. On the other hand, patients may find it very difficult to describe the nature of their pain. The various types of pain are described below. SAD I. Vague aching pain. This is a mild continuous pain which has no other specific features. 2. Burning pain. It is almost like a burning sensation caused by contact with a hot object. Burning pain is typically experienced in case of peptic ulcer or reflux esophagitis. 3. Throbbing pain. It is a type of throbbing sensation which is typically felt in case of pyogenic abscesses. IV. Scalding pain. It is also a type of burning sensation which is particularly felt during micturition in presence of cystitis, acute pyelonephritis or urethritis. V. Pins and needles sensation is typically felt in case of injury to the peripheral sensory nerve, as if pins and needles are being pricked in that area of the skin supplied by the affected sensory nerve. V. Shooting pain is typically felt in case of sciatica when pain shoots along the course of the sciatic nerve. 7. Stabbing pain is a sudden, severe, sharp and short-lived pain. This is typically felt in acute perforation of peptic ulcer. 8. Constricting pain means as if something is encircling and compressing from all directions the relevant part. The pain is often expressed as an iron band tightening around the chest. It is typical of angina pectoris. 9. Distension. This type of pain is experienced in diseases of any structure encircled or restricted by a wall, for example a hollow viscus. When tension increases inside such hollow viscus, it causes a pain which is typically described by the patient as a feeling of distension or tightness. X. Colic. A colicky pain occurs when the muscular wall of a hollow tube is attempting to force certain content of the tube out of it. A colicky pain has 2 features. Firstly, the pain. A few special symptoms and signs. L3 appears suddenly and it goes off as suddenly as it came. Secondly, the pain is of griping nature, may not be very excruciating, and it is often associated with vomiting and sweating. Usually 4 types of colics are seen in surgical practice: ureteric colic, biliary colic, intestinal colic and appendicular colic. 11. Twisting pain is a type of 4 types of colics are seen in surgical practice: ureteric colic, Biliary colic, intestinal colic and appendicular colic. 11. Twisting pain is a type of sensation as if something is twisting inside the body. Such sensation is often felt in case of volvulus of intestine, torsion of testis or ovarian cyst. 12. Just a pain. Often a patient may not describe his pain. He often says that it is just a pain and cannot describe the nature of the pain. Progression of the pain. Now the patient should be asked how is the pain progressing. A. The pain may begin in a weak note and gradually reaches a peak or a plateau and then gradually declines. B. LT may begin at its maximum intensity and remains at this level till it disappears. C. The severity of pain may fluctuate, its intensity may increase and decrease at intervals. This should be depicted in a graph. Duration of the pain. Duration of pain means the period from the time of onset to the time of disappearance. Characteristically, the griping pain of intestinal colic is felt for less than a minute. The pain of angina of effort ceases within 5 minutes of resting, whereas that of a myocardial infarct may continue for hours. Movements of pain. Pain may move from one place to the other and 3 types of such movements are noticed. I. Radiation. 2. Referred and 3. Shifting or migration of pain. I. Radiation of pain. This means extension of the pain to another site whilst the original pain persists at its original site. The radiation of pain has almost the same character. The typical example is when a duodenal ulcer penetrates posteriorly. The pain in the epigastrium remains but at the same time the pain spreads or radiates to the back. 2. Referred pain. When pain is felt at a distance from its source and there is no pain at the site of disease, it is called a referred pain. Irritation or inflammation of the diaphragm causes pain at the tip of the shoulder. Referred pain occurs when the central nervous system fails to differentiate between visceral and somatic sensory impulses from the same segment. In this case, diaphragm is supplied by phrenic nerve, C3, 4 and 5, and the cutaneous supply of the shoulder is also C4 and CS. Diseases of the hip joint may be referred to the knee joint as both these joints are supplied by the articulate branches of the femoral nerve, obturator nerve and sciatic nerve. 3. Shifting or migration of pain. In this condition, pain is felt at one site in the beginning and then the pain is shifted to another site and the original pain disappears. This occurs when an abdominal viscus becomes diseased. The original pain is experienced at the site of distribution of the same somatic segment, but when the parietal peritoneum overlying the viscus is involved with the disease, the pain is experienced at the local site of the viscus. In case of acute appendicitis, pain is first felt at the umbilical region, which is also supplied by the T9 and 10 as the appendix. Later on, pain is felt in the right iliac fossa when the parietal peritoneum above the appendix becomes inflamed. Special times of occurrence. The patient should be asked if there is any special time of appearance of pain. Often patients with acute appendicitis give history that they feel pain on waking up in the morning. In fact, pain awakens the patient. In case of duodenal ulcer, pain is often complained at 4 p.m. in the afternoon and in the early morning at about 2 to 3 a.m. This is hunger pain and felt when food has passed out of the stomach and the stomach is empty. Migraine may occur especially in the morning, either every weekend or during menstruation. Headache of frontal sinusitis is often at its peak a few hours after rising. 14a Manual on Clinical Urgery Periodicity of Pain. This is often characteristic in certain diseases. Sometimes an interval of days, weeks, months or even years may elapse between 2 painful attacks. Particularly in peptic ulcer, a periodicity is noticed and pain recurs in episodes lasting for 1 to several weeks, interspersed with pain-free intervals of weeks or months. Trigeminal neuralgia often shows such periodicity and pain-free intervals often last for months. Precipitating or aggravating factors. This history is of great importance to come to a diagnosis. Alimentary tract pains may be made worse by eating particular types of foods. Musculoskeletal pains are often aggravated by joint movements, but certain typical factors should be given high consideration. Pain of appendicitis often gets worse on jolting, running and moving up the stairs. These movements also aggravate the pain of ureteric or vesical calculus. Pain of reflux esophagitis often becomes aggravated when the patient stoops. Pain of acute pancreatitis becomes worse when the patient lies down. Pain of peptic ulcer gets worse by ingestion of hot spicy food and drink. Pain of disc prolapse often gets aggravated on lifting weight from stooping position. Relieving factors. Many pains subside spontaneously and the patient's statement T must be carefully considered. Pain of peptic ulcer is often relieved by alkalis and antacids in 5 to 15 minutes, but such relief neither appears immediately nor after 1 hour. Pain of acute pancreatitis is sometimes relieved to a certain extent by sitting up in the bed in leaning forward position, and the patient prefers to sit up even all throughout the night. Pain of reflux esophagitis due to sliding hiatus hernia is often relieved in propped up position. Colicky pain of intestinal obstruction often gets relieved on passing flatus. In perforative peritonitis, any movement of the abdomen causes aggravation of pain and the patient gets some relief if he lies still. Associated symptoms. Severe pain may be associated with pallor, sweating, vomiting and increase in pulse rate. Colicky pain is often associated with sweating, vomiting and clammy extremities. Migraine is often preceded by visual disturbances and accompanied by vomiting. Pain of acute pyelonephritis may be associated with rigor and high fever. Ureteric colic may be accompanied by hematuria. Biliary colic is often associated with presence of jaundice and pale stool. Excessive sweating and cold extremities are very common associated symptoms of leaking abdominal aneurysm, dissecting aneurysm, hemorrhagic pancreatitis, etc. Conclusion. So it is clear now that pain is a very important symptom in surgical cases, and a careful history of the details of the pain may give very valuable clue to come to a diagnosis. Vomiting. History of vomiting itself is not diagnostic of any condition. Vomiting may occur due to a wide variety of local and systemic disorders. Vomiting may occur from simple gastric irritation. Vomiting may occur in FW1 functional and organic disorders of the nervous system, for example fear, motion sickness, migraine, labyrinthine disorders, meningitis and intracranial tumor. Vomiting may occur from severe pain as in any colic. Amongst systemic conditions, pregnancy, renal failure and metabolic disorders, for example diabetic ketoacidosis or hyperparathyroidism, are important. A few drugs may cause vomiting, for example digoxin, morphine, etc. In surgical practice, vomiting may occur in peptic ulceration, pyloric stenosis, gastric outlet obstruction, acute cholecystitis, acute pancreatitis and intestinal obstruction. In some cases of intracranial tumor, the vomiting is an important symptom. Inquiry should be made about the frequency of vomiting, the time of day at which it occurs, and also about the taste, column, quantity and smell of TL1E vomitus. A few special symptoms and SIGS 15. The vomitus may be of the following: TT, PES-1. The vomitus may contain recent ingested material. Such vomitus may be acid in reaction when it is probably due to gastric outlet obstruction. If such vomitus is not acid in reaction, the cause may be achalasia of the esophagus, benign or malignant stricture of the esophagus. 2. Vomit may contain bile to give yellow coloration of the vomitus. 3. Vomit containing upper small bowel contents may be green in color. 4. Feculent vomitus contains lower small bowel content TS, brown and of fecal odor. This is characteristic of advanced low small bowel obstruction. 5. Vomit may contain feces. This may be due to abnormal communication between the stomach and transverse colon, gastrocolic fistula as a complication of gastric ulcer. 6. Vomit containing blood may be of various types. The bleeding may be copious. The vomit may present pure blood or clots. Such bleeding may come from gastric ulcer or esophageal varices. The blood in the vomit may be altered to blackish or dark brown in color in contact with gastric juice. This is due to conversion of hemoglobin to hematine. This altered blood gives the vomitus a coffee ground appearance. Medicine containing iron or red wine may give rise to this type of vomitus. It must be remembered that blood in the vomit may have come from the nose or lungs which have been swallowed. Itching or pruritus is not a very significant symptom so far as hiccup is caused